Okay, we're back. Massive hemorrhage, part two. I do that to respect you guys' time. I don't want to make these videos really any more than 20 minutes. And so, massive hemorrhage, part two. We're done with the pathophys. We're done with the deadly diamond of death. Now we're going to talk about how do we actually stop extremity hemorrhage? How do we stop massive hemorrhage and major bleeding? Okay, we're going to talk about some assumptions. We are in tactical field care. Okay, we're not a roll one, not a roll two, but some of these principles do apply there still. We're safe. Theoretically, we're not receiving effective enemy fire. We actually have the ability to take care of combat wounded. Okay, so the types of bleeding. Extremity hemorrhage, that is major. Pulsatile, large volume. It is an amputation. It looks super, super bad to you, essentially. We are going to use a COTC approved tourniquet. We are not applying some made up tourniquet that you saw on YouTube of a stick twisting of string. That person's going to die. Only do that if you really don't like the person who's wounded. Like, don't do that if you're actually trying to save somebody. Makeshift tourniquets have really poor effectiveness for the most part. So we're going to use a COTC approved tourniquet. That is the Committee on Tactical Combat Casualty Care. You can apply a second if indicated, if they are not bleeding. This is one right here. This is a CAT tourniquet, combat application tourniquet. You're going to pay about $30 for this on the internet. If you're paying less than $30, it's probably fake from China. So send it back and get a real one. Go on North American Rescue or whatever. Again, I have no disclosures. I wish they sponsored me. That'd be awesome. But take this tourniquet. You are going to get most of your bang for your buck by pulling it towards you on the pull. All right? Always pull towards you, towards you, towards you, towards you, towards you. Always pull towards you. If you are pulling away from you, you are not going to get nearly the amount of strength required. Most of the effectiveness on this tourniquet comes from the pull, okay? After you get the tourniquet on and you pull it as tight as you can, then you're going to spin the windlass 2 or 3 turns. If you need to spin it more than that, you did not pull it tight enough, okay? If you're going to apply a second tourniquet, apply it right next to the first one, okay? In, care under fire, you're applying hasty tourniquets. If the person needs to be moved or whatever, it's chaotic. Hasty tourniquets, high and tight on the extremity, over the clothes. Make sure there's nothing under the tourniquet. Cans of dip, grenades, magazines, maps, all sorts of shit that's under there that needs to come out of the pockets. It's not gonna let the tourniquet do its job if that stuff is under there. So get all that stuff out, apply it high and tight. If this is a deliberate tourniquet, you have the ability to see the injury, you know exactly where they're injured, 2 or 3 inches above the wound. Okay? These are your different COTC approved tourniquets. I need to break out my paper because I don't remember all of them. This is one we just talked about, top left. This is your combat application tourniquet. We're on generation 6 and 7. The one just below that, this OD green tan one, is the ratcheting medical tourniquet. The SAM extremity tourniquet, this orange one. The one right below that is the soft tactical tourniquet wide. This is probably the second most common one that you'll see other than the CAT tourniquet with the red tab. The reason people like this soft T one is it's wider than a lot of other tourniquets. The windlass is metal, so people seem to really like that. Some people think that it works better because it's wide. I don't think it works better per se, but some people do like that. So you see that one, probably the most common. Its mechanism of action is a little bit different. It clips on there, and so all of these you'll have to get familiar with if you're actually going to use them. The next one is this tactical mechanical tourniquet in the top right, and then I'll move my face out of the way, and then the bottom one is this TX2 tourniquet on the bottom right. They also come, that 2 stands for 2 inches. There's also a TX3, which is made by the same company, but comes in 3 inches, okay? So those are the only approved COTC tourniquets. If you're using another tourniquet than that, you're wrong. It's not going to work. You are opening yourself up to risk, liability, and then mostly, you're just not doing good for the patients that you are trying to save. Cool. This is the only real tourniquet I've ever placed in real life. This has been de-identified. There's no patient identifiers on it. Something that you should definitely do. Mark the time, mark the time, mark the time. Mark it on a combat casualty card. Mark it on the patient. Write it 14 different times on the patient. Somewhere on this patient, on your card, at handoff, whatever, you should mark the time of when this tourniquet was placed. This particular individual, this was placed about 3 years ago. Again, it's the only one I've ever placed in real life. I had to run out to my truck and get it because the hospital where I was working, they didn't know what a tourniquet was, which was terrifying. This person has sliced their radial artery open, attempting to make a bong out of a plastic water bottle with a box cutter. and they had a radial artery hemorrhage. They passed out in the waiting room, had a huge trail of blood behind them. It was quite exciting. Thank God he didn't die, and it went well. After the bleeding was controlled, we basically had to give him a bunch of blood, and he flew away to far, far away trauma land, and they took down the tourniquet there. He continued to bleed heavily despite maximal effort by their part, and he had to go to the operating room to get his radial artery fixed. And so I did not want him to go away without me marking the time, and so you should also mark the time. Sometimes you'll hear myths on tourniquet placement that they cannot be placed on limbs with two bones. That's the forearm and lower leg below the knee. That is not true. Tourniquet is very effective there. It is a smaller diameter, certainly, but tourniquets can actually go down to pretty small diameter, even down to young children. But it can be placed on both bones. His injury was at the wrist, so could I have placed this tourniquet lower? I certainly could have. Maybe I was just scared and excited, so I placed it a little bit higher. But I didn't need to place it up here by this horrible tattoo or the shoulder region. I placed it lower below the elbow. All right. Okay. How to stop bleeding? That is not like that. So different bleeding. All right. We're talking about extremity compressible hemorrhage. Think non-arterial. Think scrapes, abrasions, puncture wounds from penetrating trauma, gunshot wounds, knife wounds, fragmentation. It is non-pulsatile. It can be large volume, but it's not as large volume as previous. Okay. The mainstay of treatment here is going to be hemostatic gauze. The COTC preferred gauze is combat gauze, but there are several others that are still approved by COTC. They recommend hold 3 minutes. So you make your little power ball and you put it into the wound, and then you pack your wound sort of hand over hand. You've probably seen this a million times, but hand over hand into the wound and hold pressure for 3 minutes. You do have to hold pressure, okay? This part is not optional. The hemostatic gauze, combat gauze, chitin gauze, whatever, it is not magic fairy dust. It does not go into the wound like unicorn piss and just fix everything. That's not how it works, okay? You need to put it into the wound and hold pressure. Now at the Soldier Medic Training site at Camp Bullis, they have mannequins that bleed if the pressure is not appropriately applied for the correct amount of time. So you need to hold pressure as if this person's their life depends on it, because it does depend on it, okay? So hold pressure there for 3 minutes. If it is ineffective, you are still seeing bleeding, either decide whether you need to place a tourniquet or not, if it is amenable to tourniquet placement, if that is indicated by the volume of bleeding, the instability of the patient, etc., or if there's still bleeding, pull out the entirety of that gauze and repeat the procedure and see if you can locate the source of that hemorrhage and place the combat gauze and pressure directly on that source. These are alternative Celox gauze, Chital gauze, X-Stat, and IT clamp. IT clamp is new to TCCC within the last year or so, maybe 2 years. I'll show you a picture of all that. All right, so Celox gauze, top left, Chital gauze, bottom left, combat gauze is the mother of all in the middle. This is X-Stat. This is like an injectable hemostatic agent that goes into sort of narrow tract, penetrating wounds, needs to be removed surgically. Really sort of specific, narrow indication for that one, but it is approved, does work. Some of these other ones operate a little bit differently, but the point is they are procoagulant when they come in contact with blood. And then the IT clamp here is used for most often like skull trajectory wounds, and then like neck wounds here, where basically you clip this on, like, I guess the biggest analogy is probably like a paper or a chip clip bag, like for your potato chips. You'd clip it on, you basically put it in there into the skin, you take those needles and you put it in the skin and you close the wound with it, and then it stays stuck there and it keeps the wound closed. So you approximate the wound edges with this IT clamp. Kind of a cool thing. It looks painful, but I suppose so would packing somebody's wound. That would also be painful. Okay, junctional hemorrhage. This is a tough one. So immediate pressure, as is for all bleeding. Okay, all bleeding can be if it's amenable to pressure, you should place pressure on it immediately. That will be the first step in everything. Junctional hemorrhage, you're talking neck at the junction of two body parts, right? So neck, axilla, and then high inguinal groin. So at the junction between the leg and the pelvis. These are the junctional hemorrhage site, okay? They are not amenable to tourniquet placement. Please do not tourniquet someone's freaking neck, okay? Please do not try to tourniquet someone's axilla. Like, that's not going to work. And then the high inguinal, it's often just too high to be effective. And so immediate pressure, ideally you have a friend to help you, but as you're getting the supplies, they're placing immediate pressure. But immediate pressure, hemostatic dressing into the wound, pack the wound, identify the cause of bleeding, and then a junctional tourniquet as soon as able if you carry this piece of equipment, because this piece of equipment is rather specific. We'll talk about sort of makeshift things you can do. This is notoriously difficult to control, and it requires continued monitoring. You slap a tourniquet on someone's upper extremity, even if they have an amputation, 1 or 2 tourniquets, you're probably good to go. You certainly have to monitor them. They're a crazy bad trauma patient. They lost a flipping arm, for God's sake. But, like, you're probably going to get hemorrhage control, okay? Put that tourniquet on, put a stump dressing on. You're probably going to be okay. This junctional hemorrhage, it's a nightmare, okay? Absolute nightmare. So difficult to control. It's going to bleed and rebleed. Your equipment may fall off or slip or the patient moves. So really got to emphasize the continuous monitoring of patients with junctional hemorrhage. These are the ones that are going to you're going to look back 2 minutes later and they're going to have bled out and died. Okay. These are your different COTC approved ones. Okay. So on the left, we got this stupid looking one. In my opinion, it just seems less feasible than some of the others. I think this one would be good. In a fixed environment, so non-dynamic environment, not in a vehicle, not in a helicopter, you are at a roll 1 or roll 2, and you're not really going anywhere in the immediate, time frame, you could use this one. This one on the left is called the IT clamp, okay? Basically, you put this part under the patient, the base part under the patient, and then you screw this ball, screw down onto the area of bleeding, and it places direct pressure there, holds your hemostatic gauze there, whatever dressings you have there, it pushes down on them. Patient can't move. Okay. This one is the SAM junctional tourniquet. If I had to pick one, I'd probably pick this one. That's not based on any specific data, or even, like, in all honesty, it's not even really based on practical use. I haven't used this in real life on a real trauma patient. It only in simulation and training. But basically, this one, it looks like this SAM pelvic binder. But if you can see right here, there are 2 pneumatic bladders that you pump up with air, and they hold pressure in the site that you want. Okay. Problem with this one, right? It's multiple pieces. This, like, freaking, pump part that you pump up the bladders with, that separates. So could you lose that? Totally. Could it fly out of a helicopter? 1000% could. Could you lose it in the trauma bay? Definitely could do that. And then this thing becomes useless. It's just a pelvic binder, which we'll talk about later. That could help you. This one is called the JET. I had to look up what that was actually stood for. So Junctional Emergency Treatment Tool. Okay, so similar concept to the SAM, except these are mechanical. They screw down, and this square part pushes into the area of junctional hemorrhage. One slip of the person wiggles around, bucks or whatever, and these are just going to slip right off. Okay, same thing happens with the SAM. They could just slip off if the patient moves. Same thing with the IT. Okay. All right, pro tip from a pro. I have a friend who is involved in Army Special Operations, and I reached out to her and said, hey, what do y'all do? What do the pros do to combat junctional hemorrhage? Because that is really, like, the area where we're really trying to find solutions. And she gave me kind of 2 solutions, one from an assault medic and one from herself. So this person, their go-to was pelvic binder plus lacrosse ball. Okay, so take a pelvic binder, axillary or high inguinal, stuff it with your combat gauze, place your lacrosse ball there, tighten your pelvic binder down, and keep the lacrosse ball over the area of pressure. That's where you want it. That was her favorite thing to do. She reached out to one of her assault medics, which is basically one of the tier 1 medics in JSOC, and what this person's go-to was pelvic binder and small Nalgene. Smaller than this, not this big 32-ounce one, but a little bit smaller. And they used a metal one. The plastic ones are very good, and so you probably could get away with the plastic ones. I've heard of the plastic ones before, but this person had a metal one. Same concept, though. Hemostatic gauze, direct pressure, pelvic binder on with the Nalgene in between the pelvic binder and the hemostatic gauze, applying constant pressure. Okay, this literally must be constantly monitored because you could easily see it could just slip out and fall. But that was those 2 people's opinion. I think that's probably as good as any, certainly based on experience. Okay, both these people have been in Army SOF for quite a long time and JSOC for quite a long time, and so their experience is expert opinion. But again, it's a tricky problem to have. So there's no great solutions for this tricky problem, but that's something that you can think of if you don't have, certainly the stupid metal alligator one, then the SAM one, and JET. Okay. I shouldn't hate on the IT clamp, but just doesn't seem very feasible. All right, bleeding stopped. Now what do I do? All right, you had a hasty tourniquet. It was high and tight. It was dark. You weren't really sure where the person was bleeding from. It's over their clothes. Now you have more time. You can clearly see where the wound is. It's actually like much more distal on the extremity. Distal means further down, so far away. It's not at the shoulder. It's actually down here in the wrist or whatever. You can, if you still believe that a tourniquet is required, you can move your hasty tourniquet high and tight down to a deliberate tourniquet 2 to 3 inches above the wound. Basically, how I would do that is I would take a secondary tourniquet. If you have your first tourniquet here, I would take a second tourniquet, place it more distal, 2 to 3 inches above the wound, tighten that down, cinch it down, and then I would loosen my more proximal hasty tourniquet and make sure that bleeding is still controlled. What I would not do is just remove my hasty tourniquet and then place a deliberate one, because you're just going to have bleeding, and all the clot and all the hemostasis that you may have achieved previously is now gone. So keep the original tourniquet on while you put the new tourniquet on, and then when the new tourniquet is finally down and cinched tight, then you remove the old one. Tourniquet conversion. Okay, if your patient is meeting these criteria, then you can attempt to convert the tourniquet. What does convert the tourniquet mean? Convert the tourniquet means move from a tourniquet, which is causing significant limb ischemia and tissue death, but is used to save their life, down to a pressure dressing, which is hemostatic gauze and pressure with like an ACE wrap or one of the North American Rescue, dressings that are these like smaller 3-inch to 6-inch dressings that you can apply. Okay. The goal of this is to decrease the ischemic limb time and certainly create more comfort to the patient, have improved functional outcomes. Tourniquets are very safe. You can use tourniquet, up to 6 hours for the most part without distal limb ischemia. But once you get beyond 2 hours, you will start to have potential neurologic problems, nerve damage that can be permanent, and you can also cause some muscle problems greater than 4 hours. And then after 6 hours, greater than 6 hours, you can have, limb loss. So you do have a long time, but when you're talking about, really long transport distances, especially in places like Africa or whatever, or you have to hold the patient for a long period of time, you really don't want that tourniquet to be on there unless they have to have it on there to save their life. Okay, so if they're meeting all these criteria, meaning the patient is not in shock, they're not hemodynamically unstable, they can be monitored, they do not have a limb amputation, and the tourniquet has not been up for greater than 6 hours, you can attempt to convert the tourniquet within 2 hours of placement to a pressure dressing. Okay? All right, final thoughts. We're at the end, guys. Knowing why we die is the most important step to figuring out how to stop death. You can't stop something that you haven't defined. Okay? Don't let people bleed to death. Don't let people bleed to death. Don't let people bleed to death. This is the biggest preventable cause of death on the battlefield. This is what, if we're going to be good at anything, we got to be good at this. We'll cover the principles of resuscitation in future videos. I'm very excited for those, about how to actually save someone after, you put the tourniquet on, you're bagging them, now what? Okay? But we got to get on the same page before that. Next up is going to be airway. We're going to go through our March algorithm: massive hemorrhage, airway, respirations, circulation, head injury, hypothermia. Next up is airway, and so I'll be looking forward to that. I'll get that going in the next couple weeks. Thank you guys very much.